video. So I am recording this presentation, and I'll put it up on YouTube later on if you think that other people would benefit from watching it. So I'm gonna go ahead and share my screen and share that, and thumbs up if you guys can hear me. Great. All right. So this statistic came out from a paper from the Institute of Medicine back in 1999. And the result of that paper was that 98,000 people die every year in the United States alone due to avoidable medical errors and injuries. And that's such a significant statistic to me. 98,000, nearly 100,000 people dying every year just in the United States from avoidable medical mistakes. So I'm going to talk to you a little bit about some experiences that I've had in leadership over the years and how they relate to things like aviation and human hospitals and that kind of thing. And just a note that I think that this slide really illustrates leadership really nicely. And when you talk about leadership, normally you're thinking about somebody that's forging a path and other people are following them. But leadership is actually supporting the people that are underneath you so that they can succeed. And kind of the really nice saying that I've heard is that when people that have a great leader succeed, they think they've done it themselves. Okay, and so it's not about getting all the glory for being the lead, the amazing leader. It's about making or empowering people that are your charges to think that they are doing it themselves and really making them feel like they are that they're accomplishing something. So part of this discussion goes back to aviation. And, I showed, specifically a Qantas airliner because Qantas has never had a flight-related death or equipment failure-related death in the entire history of the airline. It's the safest airline in the world, which I think is amazing. In the 60s and 70s, when airline transportation was really accelerating and accelerating exponentially as far as the number of passengers and that kind of thing. 60s and 70s, they had numerous airline crashes that, things from, running into the side of a mountain or running out of petrol or, crashing into a swamp kind of thing. And I remember when I was little, I was born in 1965, it seemed like every month there was another airline crash early on where, hundreds of people would die. And I was actually quite afraid early on of traveling by airplane. So in the 60s and 70s, to give you some examples, there was, in this photograph is an animation or a simulation of what actually happened. But in Tenerife, in KLM Airlines, the head of safety for KLM Airlines was also a pilot. And he was on the runway in Tenerife, and it was about 8 o'clock at night. It was getting foggy. They had been grounded for about 2 hours because of the fog. And then they were coming up on in 5 minutes, they were coming up to a deadline where if they passed that deadline, they were going to have to ground the airplane overnight, and everybody was going to have a rest because of specific duty cycles and schedules that airline employees have, where pilots can't be on duty for a certain period of time, flight attendants and that kind of thing. And he just got fed up with waiting. And he basically said to the control tower, "I'm taking off." And they said, "Okay." And he took off. And in the middle of the runway, he ran into another 747 and 547 people died. This was the head of safety of KLM Airlines. There's another story, and I remember this, of a controlled flight into the Florida Everglades. And what does a controlled flight mean? That means that they didn't run out of petrol. They didn't have an engine fall off. They didn't have a catastrophic bird strike accident like with Captain Sully on the East River. They just ran into the ground because they didn't realize that the altitude was dropping, and they controlled flight straight into the ground. Everybody died. There was another incident where an airplane ran out of fuel in Portland, Oregon, and it was circling the airport, and basically they just ran out of fuel. The airplane crashed, everybody died. They analyzed all of these accidents and found out a recurrent theme where, number one, subordinates preferred to crash and die rather than raise a concern about flight safety to the pilot. So they were so afraid of being yelled at because of this hierarchy in the cockpit that they would rather crash and risk dying than raise a concern. And that raised a real issue about the culture in the cockpit. So they had a recognition of a need for change in the 1980s, and they came up with this term called crew resource management. And the overwhelming or all-encompassing theme with crew resource management is a change in culture where initially an error was viewed as weakness, leading to shame and blame and punishment, and they were converting to a culture of learning and teamwork. So in CRM, human errors are immediately analyzed transparently and completely for what they can teach about systematic errors that can help them prevent, manage, or contain effects of errors. And critical in that was defining roles of team members as well as the leader. And it was a change in culture where the captain is no longer the king of the castle. The focus is now on efficient and effective management and functioning of the entire team. So how can you work together and maximize the benefits of this team that's working together? And so the job of aviation team members became not to blindly obey orders, but to constantly inquire, contribute, advocate, and assert. And in the most extreme conditions, to even intervene to make sure that the safety of the aircraft and the passengers is supported or ensured. So it was a completely new culture in aviation, and the industry was completely devoted to extensive resources regarding team socialization and education, with frequent retraining to keep the skills current. And you can imagine that, you know, you can picture or recall an image of the captain walking down the gate, and just everybody looking at him like, or him or her like they were a god, and they had to combat that culture. And you can imagine that the captain that's used to being the king of the castle is going to be resistant to this. So it's not something that they snapped their fingers and it changed overnight. It took decades to reinforce this change in culture. So with CRM, you're utilizing all the resources and information available. Decisions and information are constantly shared and updated. And team members are redefined as not being obstacles to the captain's authority, but a crucial human resource. Then the intent is to make flight safety and the captain's job easier. Now, I want you to, as you listen to this, to start thinking about the parallels that we would have between medicine and aviation. So there was a new paradigm in aviation where every team member is empowered to monitor all the other team members, and all members of the team, regardless of rank, status, or position, were encouraged to point out to any other team members with sufficient urgency and clarity if they were concerned about something. So there's a 5-step assertive statement process. You know, opening or attention getter. Captain, I have a concern. What is your concern? My concern is that one of the engines are on fire and it's probably going to fall off the plane. State the problem as you see it. Well, if the engine falls off the plane, there's a possibility that we're all going to crash and die. State a solution. I think we should land immediately. Obtain agreement. Captain, do you understand and agree with me and what I'm saying? And so you have to empower all the team members so that they feel comfortable having this kind of conversation, even with the captain of the pilot of the airplane, or for that matter, the head clinician in a medical practice or in a veterinary practice. So imagine as a veterinarian, I mean, human doctors have a lot to think about, but veterinarians have even more to think about. So you're constantly worrying about keeping up to date with the literature. You're often the HR manager, you're doing payroll, you have to keep track of stocks to make sure that you have enough consumables in the practice to keep it running. You have clinical issues, you have disgruntled clients, you have people calling in sick, all kinds of stuff, and our brains are just completely full of all of these different issues. And you can imagine that it would be easy to make mistakes. So contrast aviation to healthcare. This first statistic is really, I think, pivotal for me. Each patient in hospital, each human patient in hospital experiences an average of at least one medication error every single day. So every day that you're in hospital, every person in every hospital is going to have at least one mistake made every day. And so that's just amazing to me. Some of the mistakes are catastrophic and some are insignificant, but those mistakes are being made. And as I stated before, 98,000 people die every year in the United States alone due to avoidable medical errors and injuries. And when they analyzed this, they found that failures of teamwork and communication are responsible for more than 75% of medical errors and injuries. So when you make a medical mistake, is it a human error or is it a systematic failure? And the tendency is to say that it's a human error. Like, say, for example, somebody leaves a pop-off valve closed on an anesthetic machine and a patient dies. The tendency is to yell at that team member and ask them, how the hell could you let this happen? This patient's dead. I'm going to have to go and talk to this client. It was an elective procedure. What are we going to do? To recognizing that that person feels terrible as it is. It's not necessarily their fault that that happened. There's a systematic error in your hospital if pop-off valves are allowed to be left closed. And so we've had that happen once or twice in our practice, and I know that we've lost at least one patient in the last 16 years since I came to Australia. And when that happened, that team member was just absolutely devastated. And so what did we do? We analyzed the situation and recognized that we needed a checklist hung on every anesthetic machine that says, whenever you put a patient on this machine, you have to go through this checklist. And the checklist includes, is the pop-off valve open? Is the anesthetic machine full? Have we leak tested it? Is the soda lime canister, or has that been changed recently? Are there any leaks? That kind of thing. And so recognizing that that was not an individual failure, but a systematic error, a systematic problem that we had. Now, if that same person left a pop-off valve closed several times, then you might go back and think, okay, maybe this particular person is the problem. But when it happens once, you have to recognize that it's likely to be a systematic error. So let's look at that. 98,000 patients a year die in the United States. In the last 16 years in commercial airlines, there have been 153 commercial airline deaths in the United States in 16 years. 153 people, 16 years. Now, when you do the calculations, that's 160 million flights in 16 years with 153 deaths. So that's 1 in a million chance that you're going to die if you fly a commercial airline in 16 years, 1 in a million. And so on any individual year, it would be 1 in 16 million. Now, there is software, this is called planefinder.net, that you can look at every airplane that's in the air at any point in time. And this was, I just went to the website and had a look, and this was one snapshot that I took at one point in time. I think this was before COVID, but you can see that there are just thousands and thousands of airliners in the air at any minute. And in 16 years of this happening at any minute of any day, they only had 153 deaths, which I find is amazing. And in fact, your luggage is infinitely safer on an airplane than you are in a human hospital. So in the same 16 years, they had 1.5 million deaths in the United States due to avoidable medical mistakes. Imagine 4,000 completely full 747s crashing, 4,000 completely full 747s crashing in that same time period with no survivors. Now, you can imagine that if it had been a terrorist group that was causing this many air traffic accidents, that everybody would be completely up in arms and would have resolved the problem very, very quickly. But you have that same number of deaths happening in human medicine, and it still continues to happen. So how has aviation become so safe? Two different things. Number one is the use of checklists. And number two is a change to a culture of safety. And so what I mean by checklists is when you are an airliner, every single thing that happens on an airplane is run by a checklist. They have a book that's about 3 inches thick of checklists for every different event. For example, if you have a bird strike, like happened in Captain Sully's airplane, there's a checklist that you follow. If somebody dies on an airplane, there's a checklist. If you have, landing gear failure, there's a checklist. When you're taking off, there's a checklist. When you taxi, there's a checklist. So checklists for absolutely everything. And then the culture of safety is that change to a culture where people are allowed to challenge their superiors if there's an issue of safety that's occurred. There are 2 books, if you're interested in this kind of thing, that I'd really encourage you to read. One is called The Checklist Manifesto by Atul Gawande, and one is Beyond the Checklist. And Atul Gawande is a human surgeon that's written 4 books. All of them are amazing. They're all available on Kindle, very easy to read. You can get through most of them in about 3 hours, something like that. So if you have an interest in this kind of thing, I'd highly recommend that you read these books. So what happened with Atul Gawande? The way that he got involved with checklists was that he was a surgeon at Johns Hopkins University in Baltimore. And Johns Hopkins University is one of the world's largest and most well-known medical facilities and universities in the world. They had an issue back in the 90s with central IV catheter sepsis. And so what happened was that 11% of patients who had an IV catheter, a central line, got septic, and 1% of them died. Now, the way that this came to light was that there was a little girl there, a 2-year-old girl, who had a 2nd-degree burn to her feet in a bathtub. She was admitted into the hospital, had a central line placed. She should have gone home in about 3 days. But at about 3 days after her admission, she started becoming unwell, and the mother raised the flag to nurses, to doctors. Everybody ignored her. And about 7 days after admission, she died. And to the huge credit of this person, instead of suing the bejesus out of Johns Hopkins University, she decided to start a task force to try to figure out what happened and how they could keep this from happening to other children and other people. And so she was teamed up with Atul Gawande, who is responsible for looking at the concept or the idea of central IV catheter sepsis. So what they found, he analyzed all the septic patients and all the issues related to central lines. And what he found was that everybody knew how to put in a central line. Everybody was familiar, you're supposed to wear a gown, you're supposed to wear gloves, you're supposed to prep the area, you're supposed to put drapes on the area. But the problem is that the bits and pieces that were required in order to put in a central line were really difficult to find. And so you had to go all over the hospital and go to one room to find the gowns, and another room to find the catheter, and another room to find the prep material. And people in a hurry cut corners. And you can imagine when you're in a critical situation like this, that people are going to find ways to cut corners in order to save time. So the first thing that they did was they created a central line checklist, and they put everything that you needed in a single cart. So this is a central line cart that if you wanted to put in a central line, you just grab the cart, bring it to the patient bedside, you have everything you need ready to go. The other big thing was that the nurses were empowered to stop the doctor from carrying out the procedure if they failed to follow the checklist. So if they failed to prep the area, the nurse could literally put their hands over the patient and say, you can't go any further until we follow the checklist. And doctors who didn't follow the checklist and yelled at the nurses had the backup from the administration, not the doctors. Okay, and you can imagine that this is a huge change in culture. Again, the captain of the ship that's used to people cowering in their presence were being challenged about the way that they were doing things, and the people that were doing the challenging were getting the support of the administration and not the doctor. So that was a huge change. Within 18 months, they dropped central line sepsis to 0 and mortality to 0. So that's just an amazing transition. And this was, imagine the number of lives saved just by following appropriate procedure. They didn't have to buy a new $10 million piece of equipment. They didn't have to get retrained in a new procedure. They just followed the correct procedure for putting in central lines and saved numerous lives. So why use checklists? They increase compliance to proper procedure. The big thing is that they overcome failings of hierarchy. And we have checklists in our hospital where literally the procedure has to stop until you check off that point on the checklist, and you're not allowed to proceed any further until that step is completed. It provides a cognitive safety net because when you're busy, you forget things and you forget to do things. It catches mental flaws of memory, attention, and thoroughness. And I know that as I get older, I'm 56 years old now, and that I do forget things. And so having that checklist reminds me to keep, to stay up on things and to keep track. And it ensures a consistency of care. Now, I'll tell you a story. About 3 months ago, we were really, really busy, and I was about to do a TPLO, and I literally had the patient on its back at the table. I was scrubbed in, and I had my scalpel blade in the air heading toward the knee. My resident, Jeff, came in to scrub in with me, and first thing he said was, when he walked up to the table, he goes, have we done the checklist? And I went, oh, shit, okay, let's do the checklist. And the first step of our checklist in the theater is confirmed side and procedure. And I took one look at the patient and realized that we had prepped and clipped the wrong side. And so I called the owner and said, look, we've clipped the wrong side. We had a breakdown in communication. The owner had a laugh and nothing happened. We prepped the other side and did the TPLO. Now, that was 2 seconds away from me operating on the wrong leg. And if it hadn't been for Jeff walking into the theater and asking if we had done the checklist, we would have operated on the wrong leg and it would have been a disaster. And so when you're in a hurry is not the time to skip the checklist. When you're in a hurry is the time to do the checklist, because that's when you need it most. So when you create your own checklists, number one, you want to have a clear purpose. So the purpose of this checklist is to get the patient into theater. It has to be short enough to be practical. So you don't want a checklist that has 50 steps. You want 6 or 7 steps, something like that. Our intra-operative checklist is exactly 7 steps. Each step has to have a major consequence if it's missed, like operating on the wrong side, having the wrong equipment, having the anesthetic machine not set up properly. And the checklist stops until the preceding step is complete without fail. You want to include items that are easy to forget, and it must be applied every time. Like, for example, you wouldn't have as a step on your checklist, wheel the patient into theater, because you're always going to do that. That's not something that's going to be forgotten. You want to put check or confirm side and procedure to make sure that you're operating in the right place. So in human medicine, they actually have a timeout towel that sits over the scalpel, and you're not allowed to lift that timeout towel until you've done the checklist. Now, the other issue in human medicine, it's a disadvantage that they have, is that often you'll have 1,000 or 2,000 people working in one hospital. And so you might have people that aren't used to working with each other. And so one of the big steps in the human hospital checklist is for everybody to introduce themselves to each other. And often what they'll do is they'll put tape on their forehead with their name on it, because once you introduce yourselves to the other people in the theater, you are more likely to feel comfortable to raise a safety concern than if you don't know them. And so, usually everybody's on a first name basis. And then once you've gone through that initial checklist, confirming side and procedure, confirm consent of the owners, everybody's introduced themselves, etc. That's when you can lift the timeout towel and you can start the procedure. So another big step is analyzing successes and failures with complete transparency without fear for punishment. Now, this is a flight data recorder that's on all commercial airlines. And this slide is to remind me or to prompt me with the ATSB, which is the Air Traffic Safety Board, when they analyze a crash, they expect a complete transparency from everybody involved. And the reason why people can be transparent is because they know that there aren't going to be any punitive ramifications of them being honest. What the ATSB is interested in is complete transparency and not laying blame on an individual. And interestingly, the ATSB investigation is completely sequestered from the court of law. It cannot be introduced into litigation. And so all the ambulance chasing lawyers would love to get their hands on the results of the ATSB investigation, but it is completely sequestered from the court of law. And that's been supported in numerous Supreme Court challenges. But the Supreme Court feels that transparency in this process is so important that it will always be sequestered from litigation. That's the same thing with morbidity and mortality rounds in human hospitals, where people discuss the same types of failings that resulted in medical errors or death, that morbidity and mortality rounds is sequestered from the court of law. So lawyers cannot get a hold of that, and they cannot use it in lawsuits, which again attests to the importance of this and the transparency. So why are doctors resistant to change? Because unlike pilots, the doctor doesn't go down with the ship. Okay, if a pilot has a mistake or has a bad day, it's a really bad day and they don't go home to their family. Whereas a doctor has a bad day, can still go home and have dinner with their family. So changing gears a little bit, what motivates people? So when you're looking at your team members, what motivates them to do a good job? The traditional thinking is that if you reward something, you get more of the behavior you want. And if you punish something, you get less of the behavior that you don't want. And I'd credit Jane Binloss, who was one of our business managers, for putting me on to this, and then Dan Pink, who wrote the book. So as long as the tasks involve only mechanical skill, bonuses work as expected. So if you have an assembly line and you tell your assembly line workers, if we pay you more, or if you produce more, you get paid more, production is going to go up. But that falls apart once the task calls for a cognitive skill. So once you have to use a little bit of creativity, a little bit of intelligence, that whole punishment reward system falls apart. So they did an experiment where they had a task, and they took people, and the task was a cognitive task. I think it was a puzzle or something like that. And this was done in a developing country. And so what they paid people that did poorly, they got 2 weeks' salary as a bonus. The ones that did well, they got 1 month's salary as a bonus. And the ones that did really well got 2 months' salary as a bonus. So you'd think that the people that are getting rewarded the most are going to perform the best. But what happened was that the higher incentive led to worse performance. So people that were being paid more or offered to be paid more for better performance actually did more poorly, because people get freaked out, they lose their creativity, they lose their ability to think cognitively, and it actually leads to poor performance. So then they analyzed what actually improves performance in the workplace. And again, for simple, straightforward tasks like an assembly line, if you give a carrot, you get more of the behavior that you want. But when a task gets more complicated, it requires conceptual, creative thinking. Those kinds of motivators just don't work. Okay? So what does work? The 3 factors that lead to better performance and personal satisfaction are autonomy, mastery, and purpose. So you allow people to think on their own, you allow them to achieve mastery of whatever they're trying to do, and you give them a purpose. Now, what better environment to give people autonomy, mastery, and purpose than a veterinary practice? Okay? If you have a nurse, for example, that you allow them to think for themselves and make decisions on their own, you give them an opportunity to achieve mastery of putting in catheters, intubation, prepping for surgery, things like that. And then also they know that they're part of a bigger purpose, which is to improve the quality of life of your patients. It's a huge motivator and a huge opportunity to make your team members really excited and happy to come to work every day. So give you an example, at Google, they have a procedure which is that on Fridays, team members are allowed to work on anything that they want. The rest of the week, they have to work on their specific projects, but on Fridays, they get to do anything they want as long as they show their work. So they can work independently. At the end of the Friday, they present to everybody else what they've accomplished. And so that Friday represents 20% of their work time, but the that Friday represents 50% of the innovations at Google. Okay, so when you allow people, again, autonomy, mastery, and purpose, let them work on their own and then show their work, they are much, much more productive than they would be if they're just being told what to do every day by a micromanager. So tell you what our experience was. About 10 years ago, we formalized a lot of stuff that was already in place. We defined a vision, mission statement, and core values. We hired a business manager so that the principals, so that the senior members of the team could concentrate on growing the practice. And we invested in the idea that our staff is a team of highly skilled healthcare professionals rather than a bunch of employees. So we treat, and we always had, but we formalized this idea that our nurses are all healthcare professionals, and that regardless of the level, from kennel helper all the way up to the senior surgeon, they have a lot to contribute, both in man hours, but also in contribution to creative processes, refining, improving the things that we do at the hospital. So you have to remember that nurses have decades of experience and are extremely dedicated. Why not use them as the eyes, ears, and hands of the vets? And so I remember when I was a vet student and I was working at a vet practice, and I had, the vet was putting on a bandage or something, and I made a suggestion about how he might do it. You know, oh, have you thought about doing this? And I just got yelled at. And he said, when you graduate from vet school in 4 years, you can come back and tell me what to do. But until then, keep your mouth shut, which is exactly what he said to me. Now, instead, at our practice, for example, if a nurse finds a mass or something that we missed as the surgeons, and they pick it up, what we do is, number one, we have a look at it ourselves. Number two, we encourage them to do an aspirate on the mass and to look at it under the microscope and give a suggestion as to what the diagnosis might be and what the treatment, what they would recommend as the treatment. And number two, often they'll get a big standing ovation at the next team meeting, or they'll get a set of movie tickets or something like that. So we really encourage them to point out things that we might have missed. So just by way of a response on the chat, how many of you work in an environment where nurses are encouraged to think independently and encouraged to challenge the senior vets and to contribute to the quality of patient care? So just give me a yes on the chat if you work in an environment that's like that. I'm waiting. Does nobody work in an environment that's like that? How many of you work in an environment where nurses are encouraged to challenge you and to think on their feet and to contribute to patient care? If that's really a representation, so I've got a couple of yeses, but if that's really a representation of the people that are watching this video, you have a huge opportunity to improve, number one, the quality of patient care, and number two, the fulfillment of your team members. I can't encourage you enough to consider changing to that kind of attitude and mentality. So at our place, staff are all treated as an integral part of our team. No team member is any more important than any other team member, from the directors all the way down to the kennel assistants. That's the number one thing. If they're not important, they shouldn't be here. So when people make mistakes, you have to remember that people who work in the veterinary field are good people, and you have to accept that they have a genuine desire to do the right thing. And so if they screw something up, it's not because they meant to. In most cases, 99.9% of the cases, mistakes are not intentional, and they usually reflect a lack of understanding, a lack of ability, or a lack of desire to do the right thing. So lack of understanding, we can fix, we can explain it to them. Lack of ability, we can train them. If they lack desire, then that's where, that would be a signal or an indicator that maybe that's not the right person for the job. And so this slide over here says it's not a mistake to make a mistake, but it is a mistake to repeat the same mistake. And so when somebody makes a mistake, figure out what systematic problems were there that allowed that person to make the mistake, and try to encourage them and help them to improve so that it doesn't happen again. Again, if they repeat the same mistake again and again and again, that's going to indicate either a lack of desire or just fundamentally a problem with that individual, that maybe that this isn't the best place for them to work. Recognize that mistakes are signs of systematic errors rather than personal failings. And it's interesting, I really like this slide, that systematic errors, this is a bullseye here. Systematic errors are that you still have a consistency in the type of care, it just misses the mark. Whereas random errors are just all over the place. And so if you're seeing systematic errors, if something happens time and time again, you have to recognize that it's something wrong with the system that you have to fix. If things are just all over the place, that might be an indicator of either a poor employee or that you have, overwhelming systematic problems in your practice. Therefore, there's no place for berating people when they make mistakes. And we have an absolute no yelling policy in our practice. If anybody gets yelled at, first time, they're going to get a serious talking to. Second time, they're going to, there's a serious case for dismissal. We do not tolerate yelling in our practice. In the unusual case that the problem is a bad apple, that person should be dealt with professionally and managed, and then up to and including dismissal. So if that's the person that leaves the pop-off valve closed, 5 times in a row. But usually that's not the case. Usually the problem is a systematic error. So the other thing is that we encourage nurses to implement change. Nothing would be more demoralizing to a nurse than have them go to a conference, learn a bunch of new stuff, come back with new ideas, and then just be told by their practice principal, that's not how we do things here, we're not going to change. So instead, encourage them to implement these new ideas. Like if we have a nurse that comes to us and says, look, we learned about this new drug, say for example, we hadn't been using dopamine. And they say, look, we learned about this new drug dopamine that allows us to manage hypertension in our patients. And we've had a lot of problems with hypertension. And so I'd like to consider present this to the team to see if it's something that we could use. And so what we do is we tell them, okay, fantastic. I want you to make a plan, give us some research behind it to support your idea. And then we also have a discussion about the financial ramifications of the decision. They have to actually present it to us. So they'll say, okay, dopamine is going to cost us $3 per patient. And then they present it to us and we look at it and we say, okay, fantastic, that's a great idea. Now, what are you going to do to implement it? So you really empower your nurses and, and younger staff and encourage them to innovate and to improve the practice. And also, we encourage dissent. So nurses who catch a problem are rewarded, not yelled at. So if I've had nurses pick up a splenic mass on a TPLO, an undetected lump, picking up an osteosarcoma on a TPLO patient, and that's happened to us numerous times. And so instead of making them, quake in fear that they're going to get yelled at for bringing up something like that, celebrate them, encourage them, give them a standing ovation, give them movie tickets when they detect things like this, because it's going to save your ass time and time again, and they're going to feel like a more important part of the team. And this is a great quote from Dwight D. Eisenhower: may we never confuse honest dissent with disloyal subversion. So such an important concept. So you want to reinforce a culture of safety where staff feel free to bring up concerns without fear of being berated. Cannot emphasize that enough. So the benefits of that are you have improved staff morale, you have improved patient safety and outcomes, you get increased productivity, you get increased profitability, and you get improved staff retention. I mean, in mental health is such a big issue nowadays amongst veterinary team members. Why wouldn't you implement something that's going to make people happier and is going to help you retain your staff? When you lose staff, it costs so much money to retrain people. Why don't you keep and empower the staff that you have and make them feel, feel that they're a valuable part of the practice? And, if you can increase productivity and profitability and get better safety and outcome, what have you got to lose? Okay, it's just a no-brainer. So at our hospital, nurses never leave because of boredom. They sometimes leave because they're overwhelmed. because they have so much to do and have so much to think about because we empower them so much. But they are the other issue is that when they're so thoroughly depended on, they're not territorial. So I've been in places where nurses say, you're not going to, one will say to another, you're not going to do a thoracotomy. That's my job. Whereas in our place, people are so excited about empowering younger team members and training them to do thoracotomies, to do the anesthetic on thoracotomies. They're not territorial at all. They're genuinely excited to have new nurses join the team and take pride in teaching them skills. Nurses who are respected, given intellectually challenging roles, and nurtured to perform at their best almost universally treat others fairly and with respect. So when you have an environment where you have bickering and gossiping and things like that in your nurse team and your vet team, for example, that is an indicator that there's some underlying systematic problems. Again, when you treat people with respect, keep them challenged intellectually, nurture them, help them develop, they're going to treat each other with respect. So why are we here? As veterinarians, we have a desire for personal career fulfillment. That's why we all join the industry. We want to make a living. We want to help people and animals. Generally, it should not be to feed our egos. If you want to feed your ego, probably being a veterinarian is not the best way to do it. So the big things are we want fulfillment and a desire to help, and all of the above are satisfied by changing to a culture of consistency and safety for staff where innovation, dissent, and improvement is encouraged. So shift to a focus of what is right instead of who is right. So hopefully this will generate a robust discussion. Do you guys have any comments or questions for me about this? You can unmute yourself if you like. Any questions or comments? Feel free to put it on the chat if you'd like instead. Does this resonate with people? Just give me a thumbs up.
Very much.
Yep, everybody excited and motivated to make some changes? If you have people that want to come and spend some time at our hospital, particularly after we're going back into lockdown tonight at midnight for another week. But when we're finished with that, if anybody wants to come and spend a day or a week with us or an afternoon or something and really get a feel for what our place is like, I think that you'll really benefit from it. I mean, we are absolutely 100% a team. Everybody's on first name basis. Everybody's treated with respect. Everybody's encouraged to contribute. Any questions or comments about anything? Are you guys in stunned silence?
Stunned silence, yeah.
Yeah.
Very encouraging.
Yeah. Excited about potential for change?
Absolutely.
Yeah, great.
In life, in life in general, not only in practice.
Yeah. Yeah, for sure. Any questions or comments? All right, we might leave it at that. And you can certainly email me if you have any questions or comments. I think all of you have my email address, or you can just email at admin@vetdojo.com. Or my personal email address is ckuntz1@mac.com. So CKUNTZ, the numeral 1 @mac.com. And if you need any advice on how to implement some of these changes. All righty. Thanks a lot, guys. We'll go ahead and wrap it up.
Thank you.
Thank you.
Charles.